The changes to emergency services at the Friarage are of great concern to many of you and me. As a follow-up to the public meeting I held on this topic a few weeks ago, today I'm sitting down with one of the key decision makers from the Trust so that we can put across our questions and get the answers that you deserve. Dr Clements, thanks for joining me today. Maybe we could start with just explaining your role at the Trust.
So I'm the Deputy Chief Executive of South Tees Hospitals Trust, and I'm also the Medical Director responsible for the Friarage Hospital.
And you're also a practicing doctor, is that right, in this field?
Absolutely, I'm an emergency medicine consultant.
Okay, very helpful. And you are, is it fair to say, one of the key decision makers around these changes?
So I've led the changes, and I've worked with the clinicians of the Friarage to come up with these changes, yes.
Now, so in a nutshell, could you just straight away explain what are the changes in a sentence? What is happening?
So these urgent changes have had to happen because of around the grounds of patient safety. We're changing from an A&E department into an urgent treatment centre, which will be open 24 hours a day. And we'll have a medical take, which is ill people can still access the hospital, but in a limited time frame.
Understood. And obviously that is going to mean a change, which we'll get into in a minute, about what exactly the Friarage can still do and not do. But what is driving these changes?
So it's a workforce shortage. For many years we've struggled to have enough doctors at the Friarage Hospital to provide the services that we need. But the key shortage we have is anaesthetic doctors with critical care skills, and we just do not have enough of them to continue running our critical care service.
So this is an issue about finding people, doctors in a particular specialty to staff various roles. And obviously we've spoken in the past about this. This is not a new issue that's come to light. How hard has the Trust tried? I mean, when my constituents email me, when I ask, we're talking a relatively few number of people, I understand, a handful of doctors, consultants that we need. How hard have you tried to recruit these doctors?
So the Trust has spent thousands of pounds on advertising for consultants in various normal journals that you would. We've done online recruitment attempts, we've attended recruitment fairs, and we've also used companies who find specific doctors for a finder's fee. All those avenues have been tried.
And is this something that you've only just started doing now, or have you been working on this for a while, knowing that these issues were coming down the pipe?
So these issues, we've been trying to support the changes for 18 months to 2 years in a significant way, and that's when we've been refocusing our attention to see if there's anything we can do. But for many years there's been issues of the Friarage with the recruitment, but we've upped our efforts over the last 18 months considerably, and we've spent an awful lot of money trying.
Well, one of the things I've been doing in my work is identifying some specialist recruitment agencies that help fill hard to recruit vacancies. They work with overseas doctors as well. And I've introduced one to you in the past. I know you were looking at it. Is that something that you are now actively looking at, or have we given up at this point on trying to find these doctors?
No, we're engaged with the agency you put us in touch with, and they have identified some candidates for us. The issue will be around absolutely ensuring they can deliver the care that we need. And they're actually going to come to us, but we are actively exploring that avenue.
And have you used bonuses and other financial incentives, which I understand are available under the NHS, to try and recruit these doctors?
We have. We will offer relocation packages. We will offer other incentives for people to come and work at the Friarage Hospital. So we're not averse to that at all.
Okay. Now, the thing that I get asked probably most often is the James Cook is just up the road. It's a very large pool of anaesthetic consultants working there. They all work for the same trust at the end of the day. You employ all of them. Why can't their contracts require them to work across two sites? I mean, many people's job requires them to work in two different places. Why is that not possible to get these consultant anaesthetists up at the James Cook to come and also work at the Friarage to cover this rota?
So their contract does allow for that, and I can make any of the consultants at the James Cook University Hospital come and work at the Friarage. So that isn't what's stopping the support. A lot of those consultants have been supporting the Friarage Hospital for many years, and especially so over the last 18 months as our workforce problems at the Friarage became worse. Unfortunately, we do have gaps in our consultant workforce at James Cook, both across critical care and anaesthetics, but most of those anaesthetists at the James Cook University Hospital do not look after the critical care unit in their normal day. So there's a skills issue here that we can't move them en masse to the Friarage. They will not have the skills to manage a critical care unit. I think there's a misconception out there that an anaesthetist can look after critical care. Some of them can, but some of them can't.
So just so I'm clear, our shortage at the Friarage is around the critical care unit, right?
It is.
And my understanding is that the consultant anaesthetists that have been, or the consultants who have been manning that unit during the day at the Friarage up to now, have been general anaesthetists who were also able to cover critical care. Why is that possible, but the James Cook anaesthetists are not able to come and do that?
So in the past, anaesthetists could look after a critical care unit, and that was how things used to work. Now, when you come out of training, you have to have specific qualifications in intensive care medicine, and you can't work in a critical care unit as a significant part of your job without that credentialing, and that's from the Royal Colleges. So an anaesthetist who doesn't come out of their end of their training with that credentialing cannot work in a critical care unit. So the two training programs have diverged, and you need extra training to be a critical care doctor.
And this training and this guidance, is that something that is, you alluded to colleges, who is coming up with this guidance? Is that a government department? Is it you yourself?
No, it's the Royal Colleges, it's the Royal College of Anaesthetics and the Faculty of Intensive Care Medicine. So that they are setting the training standards for the doctors coming for the future, and they need to have the right skills to manage patients in those areas.
And what they're saying now is you cannot staff a critical care unit with general anaesthetists. They need to be specially trained intensivists or...
Absolutely.
Right. Well, we've got some of those at James Cook as well, I know.
We do.
And why... Same question, I guess. Why can't some of those doctors also come down to the Friarage?
Well, they have been supporting the Friarage over the last 18 months, but the gaps at the Friarage Hospital rota have unfortunately been increasing. And we do have a shortage of intensive care consultants at the James Cook. We have to man a general and critical care unit, a neurosurgical critical care unit, and a cardiac critical care unit. And we don't have enough critical care doctors to manage those highly specialist units. We have between 3 or 4 vacancies of those particular types of doctors. So we haven't got a huge pool that we can spread to another site. In fact, we've already got gaps at the main site.
Right, and I mean, that said, there are some gaps, but also there's gaps here. We try not to say that some gap is more important than another. If they were spread over both, admittedly there would still be gaps, but it would mean we'd be able to keep a service open here. I presume you've asked them if they would be comfortable to transfer down here, and what has the answer been?
All of them, a significant proportion have been working at the Friarage, but the gaps have got so great that the gaps they would create in the James Cook service would mean that service itself would become unsustainable, and we would take out those specialist services from the whole geographic area, including the Friarage population, because those specialist services not only provide care for the Durham and Tees Valley population, those specialist services are actually explicitly for this population here. Those neurosurgical treatments, those cardiac treatments, and those high-level intensive care treatments treat this population.
And why is it, in a nutshell, that specialist intensivists for critical care are slightly less willing, it seems, or to work at a hospital like the Friarage?
When you come out of training now as a critically intensive care trained doctor, you want to work in a large centre. You want to work where all those very high-level, very specialist services exist, those cardiac services, neurosurgical services. You don't feel like you would like to work in a very small unit, which the Friarage would be or is the smallest critical care unit in the country. They feel very vulnerable working in small numbers. They like the support of their colleagues, and they do like to be working at the cutting edge, where many services, because medicine has advanced, have centralised in those specialist hospitals, and that's something that really we can't turn back from. And we have to accept that specialist services have become more centralised.
Okay, that's helpful, because from my perspective and constituents' perspective, we think North Yorkshire is the best possible place one could live. The Friarage is a lovely hospital, but it's helpful to understand the medical reasons why that might not necessarily suit somebody's specialist training. Now, obviously, you know the area. It's very rural population. People are travelling a long distance from Swaledale, Wensleydale to get to the Friarage. Obviously, there's going to be increased travel times involved as a result of these changes. Isn't that just bad for patient safety, having to travel further away to wait longer until you get to the hospital? Aren't lives going to be put at risk because of those extra travel times?
No, I think that's absolutely key that isn't the case. Patients who require the treatment for stroke, acute heart attacks, for major trauma have been centralised prior to this change. So you always needed to go to the major centre. That has not changed in the changes that we have created now. The patients who were still going to the Friarage Hospital were patients who had conditions of maybe pneumonia, or other infections, and that their immediacy of treatment should not be affected by that small addition to their travel time.
And that's really important and key, and I just want to make sure I understand. What you're saying is for the kinds of illnesses or sicknesses that people are going to be affected by with these changes, they are not likely to have their health outcomes impacted by the incremental travel time. Is that the right takeaway?
No, the patients who have those time-critical lesions and those highly specialised problems on stroke, heart disease and major trauma already were bypassing the Friarage, and there's very clear evidence that centralisation of those services saves lives. Yeah. So that hasn't been impacted by this change.
No, that clears that up. But obviously we'll have an impact on the ambulance service. You're going to have ambulances doing longer distances, meaning that they're away for longer. Have you spoken to Yorkshire Ambulance Service about their capacity to handle these changes? Does it mean we need more ambulances, and is that happening?
So we've had very detailed conversations with the Yorkshire Ambulance Service, and I must say I'm very grateful for them, because they have put additional resource in place, and that's to mitigate any of these additional travel times. We've also worked with Yorkshire Ambulance about how we can repatriate patients from the James Cook who end up there because of their movements out of hours, and we will repatriate patients back to the Friarage Hospital as soon as practical, and that's actually what's happening today. We are repatriating those small numbers of patients who have ended up at James Cook, and I think that's working incredibly well. So I'm confident. We've been running the new model since the 27th of March, over 2 weeks now, and there have been no instances of delayed assessment because of the ambulance service changes.
I mean, you've done a lot of modelling about what this means. They sound to me and to everyone watching probably like quite significant changes. How many people are going to be impacted by these changes?
So we believe in our original modelling that over 90% of the patients who were being treated at the Friarage Hospital will be treated in the new model on these temporary arrangements. And actually, since the model has come into place, even greater than those 90% have been treated at the Friarage Hospital. So I think we overestimated the patients who would be moved. I know it's very early days, but definitely we've been treating more than 90% of patients at the Friarage, continuing through the Friarage.
So just to make sure we understand, even though these sound like very significant changes, as it turns out, 9 out of 10 patients that used to go to the Friarage for their emergency needs are still able to go and be treated there.
Absolutely, and we as a trust would like to make that a zero impact if we possibly can. So we would like to try and repatriate some elective surgical work, which we've talked about, and we're well on the way to try and do that. So in the end, we would hope to find the net movement of being virtually zero.
Okay. Now, money comes up a lot. NHS is getting a lot more money, but it's never quite enough. Is this just a way to save money? Is this simply a way for the trust to save money by moving these things?
Absolutely not. And if there weren't the workforce problems that we've been experiencing over the last 18 months, we would not be doing this. This has only been driven by workforce. It's not a financially driven plan. When the work streams were built up, they were not given a financial envelope to work in. And actually, when we've netted the total changes and the new model changes, that will actually cost the trust an extra £1.7 million to deliver. And that's around some of the enhancements in our services that we put in place. So our acute medical model, we need more acute medical consultants that are expensive because we're bringing them to the front door of the hospital. And that actually is an enhanced service which we're going to be very proud of moving forwards if we embed this model. Our urgent treatment centre is going to be a national specification, reaching all the high standards that have been dictated, and we do need to recruit nurse practitioners to deliver that. So I'm proud of those changes, and I think I would see that many of those services have been enhanced. And so
but all those enhancements are costing more money, so the new service will cost more money than the current service?
The net effect to the trust
will be a financial
deficit
outlay
of £1.7 million.
Okay.
Yeah.
Thanks, Pierre. I mean, you mentioned some of the benefits of the new model. You've talked before about children. I have 2 young children. What will change around children? Because it seems to be one of the things that might be an enhancement.
So before, we had an adult A&E department and we had a paediatric minor injury unit. So you couldn't attend that service if you had a child who was unwell, if they had a rash, a cold or a fever. Under the new specification for an urgent treatment centre, absolutely you can attend that department, and children have been coming in much greater numbers since the service change occurred.
And is this new model something that you've worked on with the doctors at the Friarage? Are they supportive of it?
This is absolutely a Friarage model that was developed by the teams at the Friarage Hospital, and I think they're very proud of what we've put in place.
And that sounds potentially good and promising. And the worst thing is if we're sitting here again in a year when we're back here and there's a new recruitment issue of some other specialty or something else, which means even this new model then has to be further downgraded or changed. You've talked about having a 10-year vision for the Friarage. You think this is part of it. Are you sure that this is a sustainable model now and that we are not going to be having these conversations again?
So one of the things that we're very clear on is that we believe this is a sustainable model. But we do need the model to be finalised. You can't recruit to a model that's in doubt. And we do need to make appointments, especially of acute physicians, to support this model. And without that, we can't stabilise the model. So this constant thought about what the future looks like doesn't help with recruitment. So we believe that if the answer is finalised, absolutely we can be still delivering the care like we're delivering today in the next 10 years.
And there's been a suspicion, as long as I've had this job, that the trust just don't like the Friarage. They see it as an irritation, as something that they would rather just not be there, and ultimately drip feeding or cookie cuttering the services bit by bit will mean that ultimately the hospital will just get closed. Is that the plan?
That's absolutely not the plan. I am very proud of being the medical director of the Friarage Hospital, and I sit on the board, and I will look after the Friarage Hospital. And we will deliver as many services as we can safely at the Friarage Hospital for many years to come.
Okay, well, I'm glad to hear that strong commitment. It's something that people really want to hear, and they will be reassured, I think, by hearing you say that. The last specific question I had was around the incremental pressure on James Cook and Darlington. We often see in the press every so often James Cook seems to be closed to emergency admissions. There was some talk that A&E at Darlington might get downgraded. Obviously, this model relies on patients being able to access Darlington's A&E and the James Cook A&E. Many of them may live closer to those hospitals than they do to the Friarage. Are those hospitals here to stay with their A&E departments, and can they handle the incremental visits they're going to get from the Friarage now?
So the James Cook Emergency Department is a fantastic emergency department. I'm very proud to lead with the team there, and we have managed to absorb any additional patient movements from this model. The whole of the NHS experiences surge in patient numbers, but the incremental change has not had virtually any impact on the James Cook Emergency Department. I've heard rumours about the James Cook Emergency Department being closed. The James Cook Emergency Department has never closed in my memory, so I'm not sure where their rumours circulate from, because it just hasn't happened. We've been through two very harsh winters, but we've never closed that emergency service.
But you're comfortable, Key, that you can take the additional patients?
Absolutely.
I mean, in a nutshell then, if we're going to wind up now, what is it that you would want people watching to take away? What are the key messages that you'd like to leave people with? So
the message I would like to give is the model that we put in place at the Friarage on a temporary basis, because it was an emergency action. We believe that model has been built up by the doctors at the Friarage Hospital because they believe that's the answer for the future. An awful lot of work had gone into that model. I think it is the right model. The previous model was dependent on these anaesthetists and intensivists that we've been talking about. Fortunately, our new model is innovative and doesn't rely on those doctors. So the risk, we believe, has been taken out of that, and that's why we believe it will be a sustainable future. But we do need to find out what that final future looks like, because once we've done that, we can really start recruiting to that model. And this doubt about what that model looks like moving forward is one of the things that impedes recruitment. And so I would ask people to get behind this model. We believe very, very strongly that it's a good model. It will deliver high quality care to the local population. And we believe that we won't be back here again in a few years' time talking about what other services are being removed. In fact, what we should be talking about is bringing back further services to the Friarage once we've stabilised those services.